Vanita, I believe you're muted. We can't hear anything.
Joe, Vanita is muted. We cannot hear her talk. Joe, you're muted as well.
Goodness.
Okay, hold on, we'll adjust.
I am so sorry, everyone. Let me start again because her ideas and the thoughts on her, I don't want you to miss. It is my pleasure to introduce Alicia Zaveri, who will be conducting our workshop today on seniors and arthritis. Ms. Zaveri is a board-certified physician assistant specializing in rheumatology. She currently works with Dr. Daniel Baghdadi, seeing patients at the Fairfax and Rockville locations of the Arthritis and Rheumatism Associates. Ms. Zaveri has an extensive educational background and experience in her field. She was born and raised in Baltimore, Maryland. She attended Thomas Jefferson University in Philadelphia, PA, where she received her Bachelor of Science in Health Sciences with a minor in psychology. Before Pennsylvania School, she worked as an emergency department lab technician and volunteered with the local fire rescue company as an emergency medical technician, EMT. Alicia completed her Master of Science in Physician Assistant Studies at Thomas Jefferson University, which was a direct entry program she matriculated into from her undergraduate studies. While in PA school, she serves as the chair of diversity and inclusion of her PA class, organizing fundraisers, volunteering, and advocating for diversity and equity within the didactic year curriculum. During her clinical year of PA school, she was awarded the recognition of becoming a Future Educator Fellow through the Physician Assistant Education Association. She attends the annual PAEA Education Forum Conference, where she has presented on the importance of mandatory child abuse awareness and training in didactic PA education. Alicia is also a current member of several professional societies, including the American College of Rheumatology, the American Academy of Physicians Assistants, the Pennsylvania Academy of Physicians Assistants, the Physician Assistant Education Association, and the Maryland Academy of Physician Assistants. Ms. Zaveri volunteered with the local fire rescue company as an emergency medical technician. Her volunteer work also includes serving as an EMT, participating in the Big Brothers Big Sisters program, and volunteering at her local community hospital. During her undergraduate experience, she studied abroad in Costa Rica, where she refined her medical Spanish skills and volunteered at a community daycare caring for underprivileged infants and toddlers. In her free time, she enjoys cooking, reading, writing, exercising, and traveling. She speaks conversational Gujarati and Spanish. Alicia especially values collaborating with the healthcare teams to optimize patient care. She believes that the best patient care and outcomes are achieved through compassion and education. Ladies and gentlemen, I present our speaker, Ms. Alicia Zaveri.
Hi, everyone. It's great to be here and great to meet you guys. So I've prepared a presentation about arthritis for everyone here, which I will go ahead and begin sharing. Okay, is everyone able to see the screen?
Yes.
Okay, so this is just general about arthritis. So as Vanita graciously introduced me, my name is Alicia. I'm a physician assistant that works at Arthritis and Rheumatism Associates. So here is a general presentation about arthritis. So what is arthritis? So arthritis means that there is inflammation or swelling of one or more joints. It describes more than 200 different conditions that can affect the joints, tissues around the joint, and other connective tissues. So specific symptoms can vary depending on the type of arthritis, but the arthritis usually includes joint pain and stiffness, which I'm sure a lot of you are familiar with. And so just some general statistics about arthritis is that an estimated 58.5 million US adults can have arthritis. And experts believe that this number will grow even more as our nation's population gets older. Arthritis is, increasing in the general population, and more people are experiencing issues with their joints that are related to arthritis. So currently, about a fourth of US adults would have arthritis, and even greater. This is just the amount that have sought medical care or have diagnosed arthritis, but there must be way more people out there that have arthritis that hasn't been diagnosed yet. And then arthritis is also a leading cause of work disability among adults. It's one of the main reasons why people become disabled and are able to continue their jobs and, provide for their family, provide for themselves. And arthritis is also common among people that have other chronic conditions, including obesity, diabetes, heart disease, and other general cardiovascular and high cholesterol, high blood pressure conditions. So these are some risk factors for arthritis. This is something called modifiable risk factors, or risk factors that you can change on your own. There's two different types of risk factors that put us at risk for arthritis. There's modifiable risk factors that we can control and we can change. And then there's non-modifiable risk factors, which are risk factors that you're born with, like genetics or other things that you can't control. So some modifiable risk factors for arthritis include being overweight and obese. So if someone's overweight and obese, there are studies out there that show that having even 1 extra pound of weight on your body can put 10 extra pounds of pressure on the joints, primarily the knees. So weight loss is one of the most effective ways to reduce arthritis in the knees, especially. And it just takes pressure off all the other joints. But when you're standing or when you're doing squats, when you're working, it's putting all this pressure on your knees. So we really have to reduce the amount of weight put on the knees. And so we want to try to maintain a healthy weight through healthy eating and physical activity. So I'll go over some of those recommendations later. And then infections, different bacteria and viruses. So this isn't exactly something we can control, but we can try to, protect ourselves, have good hand hygiene, good cleanliness to avoid getting an infection. But different infections like GI illnesses can lead to deposits in the joint if you're not treated adequately via antibiotics. So you will just want to be aware generally if your joints become swollen, red, or warm to the touch. This is definitely something that you should seek medical attention for, and something that can contribute to arthritis, both acute and long-term. So more risk factors for arthritis. These are more modifiable risk factors. So joint injuries or overuse. Repetitive knee bending or squatting can lead to osteoarthritis of the knee. So a lot of jobs where people are bending, squatting, lifting, you really have to be careful not to injure yourself. You want to be bending from the waist and bending from the legs, not putting all this pressure on just the knees and the back. You want to limit the amount, make sure your workplace is safe for preventing these kind of occupations. It's not just physical occupation, especially in the pandemic. We're seeing a lot more people working from home, and they're having work setups or desks that are not ergonomic, that might not be set up to continue on with having a solid work setup that's ergonomic. So you want to make sure you're sitting in a chair that preferably has a swivel and a back, and that your computer is at eye level, because if you're hunching over, or if you're putting straight on your neck or on your back, you want to make sure your screen's big enough, you're not straining your eyes looking at the screen. And then one of the most important things that a lot of people don't know about is having an ergonomic mouse setup. So having a wireless mouse is better because you have more flexibility in terms of range of motion. And they also make mouse pads that have ergonomic kind of plushy setup. So it's not contributing to carpal tunnel, which is also something we've seen a lot more in terms of incidents during the pandemic. A lot more people gaining carpal tunnel and having issues with carpal tunnel syndrome due to their desk setup. And then also cigarette smoking, we all know that's bad for you. You know, every time you see the doctor, they're going to tell you to quit smoking, you know, but cigarette smoking not only increases your risk of lung cancer and things like that, but it can also increase the risk of rheumatoid arthritis and can worsen existing disease. So a lot of our patients that we see in the office here have a risk of or have diagnosed rheumatoid arthritis. And one of the main risk factors is that they smoke cigarettes for a very long period of time throughout their adolescence and their adulthood. So, you know, we just want to make sure that nobody's smoking cigarettes. You know, we're telling our family members, people we love and care about, to reduce their smoking and try to quit smoking. And then more risk factors for arthritis. These are obviously things that we can't control. So age, right? The risk of arthritis increases as you get older. And this is, you know, relevant for almost everybody. As you get older, you know, your body is having more and more degeneration. So you can't control your aging. You know, we wish we could. Can't control your aging, and you can't control that risk factor for arthritis. But what you can control is how you take care of your body and how you nourish your body and take care of your body as you get older. So, you know, making sure that you're not putting undue pressure on the joints, maintaining a healthy weight, eating a healthy diet, getting plenty of physical activity. That's always important. And then gender, there's some gender differences where osteoarthritis, rheumatoid arthritis, and fibromyalgia are more common in women. And then gout, which is the deposition of uric acid type of arthritis, is more common in men, which can be due to genetic factors. This can be due to some dietary changes. And in terms of genetics, you know, a lot of these autoimmune types of arthritis run in the family. Rheumatoid arthritis, lupus, ankylosing spondylitis, these are all types of autoimmune conditions for which we treat and see patients at ARA. And all these three different types of arthritis run in clusters of families. And they can be associated with HLA type genes. So there's a specific gene called HLA-B27 that we check a lot of our patients for, as that can be a major genetic predisposition for arthritis, especially of this one right here, the ankylosing spondylitis. This HLA-B27 type gene puts people at a great risk of ankylosing spondylitis. And lupus is one of the primary autoimmune disorders that affect African-American women, typically at a younger age, from age 20 to 40. And this runs in families a lot. A lot of our patients will say, oh, I think my sister has lupus or my mom had lupus. So there's a major, major genetic risk factor that runs with lupus, rheumatoid arthritis, and ankylosing spondylitis. So how do we treat? How do we manage this arthritis? So there is no one cure for arthritis. You know, there's not one medication that works for everybody, but it can be treated and managed. And that's why it's important to seek medical care first with your primary care physician and then with a rheumatologist if needed, to kind of see, you know, where we can go from here. What are our options for treating and managing this arthritis? Depending on the different type of arthritis, it can be managed via injections. There's different corticosteroid, viscosupplementation injections that some of you may have received or that may have been recommended for knee arthritis. And there's different medications. You know, there's anti-inflammatories, there's Tylenol, which can kind of bring down inflammation and pain as a first line. Then there's other medications called biologics that your rheumatologist may decide to treat you with if you have an autoimmune type of arthritis. And then there's also conservative therapies. It's not just all about medications and surgery and scary things like that. You know, a lot of this can be modified via physical therapy. So we're showing a lot of exercises at the end that can help kind of reduce your chances of arthritis and kind of increase that mobility in the joints, especially of the neck, of the back, of the knees. And then patient education is also very important. You know, talking to your doctor, talking to your provider, and making sure that they're, explaining to you what's going on, explaining that you can exercise, you can lose weight, you can go to physical therapy, you can rest and ice these joints, and that can also help with managing arthritis, so things you can do at home. Let's go over some types of arthritis. So osteoarthritis is the most common type of arthritis. This can be in any joints like the knees, the back, the elbows, the hands, the feet. So osteoarthritis is typically diagnosed by clinical symptoms in x-rays. So if someone with osteoarthritis, they'll have a lot of joint pain, they'll have stiffness, but one of the hallmarks of osteoarthritis is that there's less stiffness for a less period of time than with the autoimmune conditions like rheumatoid arthritis. Rheumatoid arthritis typically manifests with someone's hands or feet, like the smaller joints, being stiff in the morning for multiple hours, whereas osteoarthritis, the stiffness is a component, yes, but the pain and debilitation is very prevalent. So usually on x-rays, we'll see some sort of narrowing or degeneration of the joint space, especially on the knees and between the vertebrae and the back. So we'll see some wear and tear and degeneration in terms of patients with osteoarthritis. And treatments for osteoarthritis, we typically rule out other autoimmune conditions or other causes to the osteoarthritis. But when we treat someone for osteoarthritis, we can use, anti-inflammatories, we can use Tylenol, physical therapy. There's a lot of different options out there for osteoarthritis, which even your primary care can manage for you prior to referring you to a rheumatologist. Another type of arthritis that is out there is gout. So gout is typically caused by deposition of uric acid, or that which forms crystals, and this typically occurs most commonly at the big toe. This can also occur in other joints like the heel, the knee, the hands, but most typically gout does deposit in the big toe. And trust me, you'll know if you've had gout. It's very tender, it's very inflamed. You want to seek care for gout immediately. But there are a lot of ways that you can reduce your risk or recurrence of gout. So with gout is typically caused by eating a purine-rich diet. And what that means is foods high in purine. So a lot of red meat, seafood, beer, wine, cheeses, all the good stuff, right? But you can't have too much of it because that will cause gout. Everything in moderation is the most important, but there is things that you can do out there like modifying your diet and lifestyle choices to reduce your risk of this type of arthritis. And then there's fibromyalgia, which is a type of syndrome which is associated with chronic pain and fatigue. So fibromyalgia, there's a lot, typically the patient is very tender, has a lot of tender, diffuse points of pain throughout the neck, the shoulders, the back, even the wrists and thighs. So patients with fibromyalgia typically have a component of chronic pain or another underlying condition that might be causing this, but they also might have primary fibromyalgia. So one of the best treatments for fibromyalgia is exercise, and especially aerobic exercise and water-based exercises like swimming and water aerobics classes. The warm water is really good for the joints and it can get you moving. And the water also kind of glides to make the joints easier to move, so there's less stiffness and less pain while you're exercising. So I definitely recommend water-based aerobics or water-based physical therapy to all of our patients with fibromyalgia. And then there's a juvenile type of arthritis, or juvenile idiopathic arthritis, JIA, which is a type of arthritis that typically manifests in children, patients under 18. And that is something that definitely needs to be managed by a rheumatologist, specifically a rheumatologist that specializes in pediatrics. And then there's, last but not least, there's over 200 types of arthritis, but we're only going over a few here. There is rheumatoid arthritis, which is typically characterized by pain, stiffness, joint space narrowing, which affects typically these joints right here, these joints and these joints. So swelling, pain can typically happen in rheumatoid arthritis. And this is an autoimmune type of arthritis. So if there's blood work done, it'll come up with antibodies like a rheumatoid factor and things like that that'll show up in the blood work, as well as on x-rays and radiographic imaging, you can see changes. And this is typically something that if you're diagnosed with or you start to have symptoms of, your primary care should refer you to a rheumatologist for this as well. So how do you manage your own arthritis? There's a Strive for 5 kind of guideline we have out there, which one is to learn new self-management skills. So basically you guys are already doing this, right? You're here at this presentation and you're learning ways to self-manage your arthritis. You know, you're learning different things you can do to modify your risks of different types of arthritis and ways that you can learn to protect your joints. So this is step 1. Step 2 is staying active, moving your body. You know, if you don't move it, you're going to lose it. If you're staying sedentary, if you're sitting all day, that contributes to more stiffness and contributes to pain. So when you're sitting in one place, think, can I be stretching right now? Can I be standing? Can I be exercising? And it's also great to do this in a group. You know, if you have a group of friends that you spend time with, or you meet up with for lunch or for dinner, things like that, you can also incorporate into your schedule, let's go for walks, especially when it starts to get nicer in March and April and the summer. You guys can go for walks together. You can join an exercise class together or water aerobics class, you know, anything that you enjoy. You just have to make it fun for yourself, and staying active is one of the most important things. And then it's also important to talk to your PCP about if seeing a rheumatologist is right for you. A lot of mild cases of arthritis can be managed by your primary care, but if you're not improving with conservative options like anti-inflammatories, Tylenol, physical therapy, it might be time to be worked up for any other autoimmune causes to the arthritis. So, you know, talk to your PCP about if seeing a rheumatologist, like at our practice ARA, is one of the right things for you. And then managing your weight. We already talked about this for a little while, but managing your weight is one of the most important things you can do to manage your arthritis. You know, maintaining a healthy body weight, you know, maintaining that mobility. And then last but not least, protecting your joints is very important as well. So when should we see a rheumatologist? You know, when do you recommend? And what is a rheumatologist exactly? So a rheumatologist, like my colleagues and I who work at Arthritis and Rheumatism Associates, rheumatologists are specialists in the non-surgical management of musculoskeletal conditions and autoimmune illnesses. And a lot of rheumatologists like to self-describe that we like to solve puzzles. You know, we're here to solve those complex cases. If you have chronic pain, chronic fatigue, things that your primary care wasn't able to help you with, or another doctor or another provider was not able to figure out what's wrong with you. Sometimes seeing a rheumatologist can really help put those puzzle pieces together and come up with a holistic treatment plan. And the way patients typically get referred to see a rheumatologist is recommended by their primary care or by their orthopedist or by their neurologist, you know, other specialists. So a lot of the times orthopedists can also manage, you know, arthritis of the knee. They can do injections too, but if the patient is not improving with injections, with physical therapy, you know, that's when you see a rheumatologist to see maybe there's something autoimmune going on here. So rheumatologists are specialists in musculoskeletal conditions and autoimmune diseases non-surgically. So we were talking a lot about physical activity. How much activity overall is recommended? The American Heart Association recommends 150 minutes a week of moderate intensity exercise, such as walking, or 75 minutes a week of vigorous intensity aerobic exercises, such as bicycling, going to the gym, swimming. And I know this is a big number, and I'm not saying that, you know, you have to count every single minute of exercise, you have to meet that 150 goal, but that's just the recommended goal to stay healthy and to maintain a healthy body weight. But overall, you know, any physical activity is better than none, just doing anything. So, you know, stretching, walking, doing exercise classes, whenever you can make time for this and push yourself to, you know, stay healthy and lose some weight, that's better than nothing. And so key guidelines for adults over the age of 65, you know, there might be a lot of mobility issues or already present arthritis. So just general guidelines also include moving more and sitting less throughout the day, you know, just stretching, standing, anything you can do. And then the types of exercises that are recommended are typically endurance or cardiovascular activities, such as brisk walking, jogging, biking, dancing, and swimming. And, you know, you want to make sure that these exercises are safe for you to do. So you always want to make sure safety comes first. So talk to your primary care, talk to your rheumatologist, talk to your physical therapist about what kind of exercises would be right for you. Yoga is also really good for stretching and keeping mobility of the joints. And then a lot of our patients like to do Tai Chi or muscle strengthening, which is also a really good option. So we do have some extra information about our program, Arthritis and Rheumatism Associates. We have a Center for Rheumatology and Bone Research, and there's a brochure and a video included about our Center for Rheumatology and Bone Research and our physical therapy department. So I also included some physical therapy exercises here, which Vanita will be demonstrating after the Q&A. So she will go through these slides with you all. And then that's all I have for my short presentation. Thank you. Visit WashingtonArthritis.com to learn more about us.
Miss Alicia, can we take questions right now?
Sure, absolutely.
Okay.
Let's see here. So there's one question. Did you say ice or eat? I have osteoarthritis. So both are really good for the joints, especially if there's swelling or pain in the knees. There's a term RICE, rest, ice, compress, and elevate. So you want to keep your legs elevated and ice the joints. And heat is also good, but you want to do alternating, and you definitely want to make sure you're not spending more than 15 minutes of a cold ice pack or a hot pack on the joints as well.
I see Carolyn.
I'm sorry, I don't know if this is an old wives' tale, but I used to hear the older people say that everybody has arthritis and babies can be born with arthritis. So is that pervasive, that it's in everybody, pretty much?
So a lot of people do have arthritis. That's a great question. So a lot of people do have some sort of degenerative changes throughout their knees or their back. Those are the most common places. You start to feel joint pain and stiffness. And babies can be born with arthritis, but that's very, very rare, the juvenile idiopathic type of arthritis. That is rare, and it's typically not something we worry about in children, and we start to see, joint pain and deformities at that age. But I wouldn't say every single person has arthritis, but as you age, that's a great risk factor for arthritis. As you age and as you put more pressure and degeneration on the joints, that's one of the most common ways that arthritis spreads throughout the body.
Oh, thank you, because my grandmother used to talk about that, and she was born in 1887 and lived to be 97. So a lot of this is anecdotal type things that they observed over life. But thank you.
Of course.
Yvonne Smith.
Yes, I was the one who asked the question about ice, but now I'm taking a gel. It's a Diclofenac, Diclofenac. And I don't know if these things you can take for the rest of your life. My friend who I visit every year, they go to something called Osteoarthritis. So and exercises and stuff, but I don't, do I need to go to a occupational therapist or something? I'm getting to the point where I can't move much.
Okay. So
I can forget for so long.
Okay, we have someone who needs to mute.
So about the Diclofenac, so that's a topical anti-inflammatory, an NSAID. So it's similar to the medications like ibuprofen that you'd be using, but it doesn't have those systemic side effects, something that you put directly on the joints. So while that's a really good conservative option for arthritis, and I would definitely recommend to continue using it, I also would recommend that if you're not improving with it, to talk to your primary care or to talk to a rheumatologist about whether other options like physical therapy or other medications would be good for you. So definitely talk to your provider about whether other options would be good for you. But Diclofenac is good. You can keep using that.
I try to I have 800 milligrams of ibuprofen, but I try not to use it unless I'm going for a walk. And you said something about Tylenol. I know there's a difference Because one time when I ended up in the emergency room before COVID started, they told me to alternate it because I had pain in the shoulder. So I don't know the difference between the ibuprofen and the Tylenol and when we should use it or not. The ibuprofen is a prescription that I have. The
Okay.
Tylenol you said would help with the inflammation. I do turmeric. I try to do everything to food and everything not to have the inflammation.
Right. So it's always good to do, those therapies of, turmeric is a great anti-inflammatory. So is ginger, garlic, natural food supplements too. But I would definitely recommend talking to your personal primary care or rheumatologist about specific medication options. I don't want to give anyone advice about which medications are right for them without knowing your full medical history. I don't think that would be safe. So I would definitely recommend talking, getting that conversation started with your primary care or with your rheumatologist about this medication, okay?
Can we hear from Cheryl Edwards?
Yes, hi, hello everyone. Okay, could you go over the RICE for me first, what it means? And then number 2 will be, how long do we stay on these arthritic medicine? And when do we know when it's time to switch off and switch to something else? Thank you.
Okay, sure. So RICE stands for rest, ice, compression, and elevation. So resting that joint, if you're overusing that joint, you have to also rest it. So getting lots of rest, and then ice, you can use ice packs or cold packs, you can get them anywhere. And you just want to make sure you're not putting them directly on the skin. There should be a layer of clothing or a towel or something between the skin. Doesn't have to be too thick, but you can put the ice on the joints, which can help calm down the inflammation, calm down that pain. And then compression. So compression, a lot of people wear compression stockings or compression socks. That is really good for when the lower extremity has a lot of pain and swelling. And then elevation. So this works, elevation, if you're sitting in a recliner, elevating your feet above your torso. If you're sitting up with your feet elevated. And then also when you're laying down in your bed, you can put a few pillows underneath your calf to kind of elevate the legs a little bit. But it's just always important to not prolong these therapies. You should use ice for no more than 15 minutes before taking a break from it. Don't keep the ice on for multiple hours or things like that. And then what was your second question?
How long do we stay on prescribed medication from the doctor? When do we know when to switch off if one is not working against another?
Right. So it's really important to talk to your doctor or your provider about your specific case, about what condition you have, what medications you've been on. But it's really dependent on which medication as well. Some medications take longer to work, some take shorter to work. But if you're having any, undue side effects or increased pain, that's not normal. And you should definitely initiate that conversation about whether this medication is right for you.
Yeah, thank you.
Okay, is there any other questions that we can ask Miss Alicia to address now?
I have a quick question. Is it normal, especially during COVID, when people are sitting around a lot in the day, and I know people are trying to get up and get movement every hour or so for a few minutes and exercising every day, but is it normal because of sitting around that there would be like tenderness at the end of the spine?
So any tenderness isn't normal, and I would definitely recommend that, you do stretching, you keep active, but you should also likely talk to your primary care doctor or a rheumatologist about this, because they might be able to recommend some additional therapies and get some imaging and laboratory tests to make sure that there's nothing underlying or autoimmune going on.
Thank you.
Okay, we're going to entertain one more question because Ms. Zaveri, she's going to have to leave, but then Ms. Williams is going to follow up with some additional activities. I see Ms. Turner. Ms. Turner, you have a question? Jacqueline Turner, go ahead with your question. Unmute yourself.
Okay. My question is, does tingling, like a tingling or numbness in the hands or feet or legs, is that part of rheumatoid arthritis, or is that a nerve damage?
So that could be either thing. You know, it's definitely important to see your primary care doctor, see a rheumatologist or a neurologist to have that evaluated. We definitely have to see, you know, what else is going on there. So there should be more testing and more things done to investigate this. I can't tell you just based on that one symptom what's going on, but I would definitely recommend having that evaluated.
Thank you.
Okay, and one last question, Miss Ruby Hoskins. Miss Ruby? Ruby, unmute yourself and ask your question. Okay, she's not hearing us. Is there any other, one last question, anybody?
Do we have to be referred to the to this doctor, or can we walk in as a new patient?
So you'll have to have an appointment to come in as a new patient. We do have a wait list and things like that, but you can, some insurance companies require referrals, but some are okay with you coming in as a new patient. So I have our phone number to our central call center, which Vanita will provide you all with, to our call center and to our website, so you can do more research about me and Dr. Al-Baghdadi and the other providers that we have in our practice. And then you can call to, you know, make an appointment as a new patient.
Cool, thank you.
Well, everyone, at this time, I would like to give our appreciation to Alicia for her fantastic presentation. Thank you so much for giving us all this information. And we are going to let her now move on to her real patients that she needs to service. But thank you again. We really do appreciate your contributions.
Of course. Thank you guys all so much for having me.
All right. And if everyone will just follow with me, Miss Alicia will talk to you again in another time, but I am going to give the rest of her presentation. Let me see if I can share the screen.
One of the things that I like about ARA very much is that this is truly a microcosm of what's happening in the rest of rheumatology. And the physicians here are open to new. They are willing to innovate. They're willing to make the next step for the patients.
A clinical research trial is a study of the medication, and we study the safety and the benefits of the drug. That helps us to know what
We're not hearing them.
Hello? Hmm.
I cannot hear the presentation.
To it. And we monitor those patients very closely. The physicians here monitor them. They're still part of our practice and are being treated by the physicians here.
The subjects really enjoy being involved with the coordinators. And thankfully, the overwhelming majority of people that we work with in clinical trials gain benefit and give back to the world.
After having a variety of different treatment options that I have been utilizing over the past years, has reached a point where I was not getting any relief. So the opportunity presented that there was a clinical trial that I might be eligible for. So there was a little bit of apprehension, but I will have to say far, far more hope that this might be an answer for some relief for me.
If a patient wants to find out more information about our clinical research division, the Center for Rheumatology and Bone Research, they can go to washingtonbone.com and it will give you a link to send a message to us, and we'll reach out to you and answer any questions you have as it relates to clinical trials. So sometimes we get family members or church members referring patients. So we try and make it as easy as we can. We know that, sometimes it's hard to spell arthritis. So we have washingtonbone.com.
So at this time, their physical therapist is also showing some of the exercises that they use.
The purpose of physical therapy is to create an environment of healing.
The beauty of having physical therapy as part of the practice and so easily accessible is that there can be tremendous collaboration between the physician and the physical therapist. I will often speak with the physical therapist directly or give them very specific instructions about what I have found in my examination of the patient. On the other side, the physical therapist will often speak with me about additional modalities that they would like to add. They will speak with me about questions about the diagnosis. That type of collaboration, that type of interaction becomes very difficult in situations with an outside physical therapist.
This clinic does help a lot in that we're not trying to rush a lot of patients in and run patients out. And we focus on the education, which takes one-on-one time. So we spend a lot more time getting to know our patients and teaching them what they need to do. And I think that's why a lot of times patients will come here who haven't had success in another clinic and see success.
Acute injuries are injuries that come on suddenly. And oftentimes the patients will, maybe fall, they break a bone, they get surgery, and then they'll have rehab for that. Or chronic diseases, this is something that can be long-term, it's been going on for a while. Sometimes the patients don't even know they have it. We treat it of diagnosis. We treat osteoarthritis.
It's always like that, I thought.
Ankylosing spondylitis, osteoporosis, stenosis, fibromyalgia. We can treat hypermobility, which is a increase in the joint mobility, and there are different levels to hypermobility. We treat general sprains and strains that someone can get from lifting something up at home, doing their daily activities, or from a sports injury. And we treat post-surgical patients.
Some of the modalities that may be used in addressing inflammation in the acute or chronic phase, from manual treatment techniques to dry needling, may include electrical stimulation, heat and cold thermal modalities.
Paraffin can be used if there's pain. It's hot wax around the designated joint. Typically it's on the hands or the foot. Ultrasound is another modality that can be utilized in physical therapy. It's to increase the mobility of the tissue and extensibility of the joint to improve again mobility and health.
But we also do place a great emphasis on addressing conditions with a manual treatment approach, where we're actually putting our hands on patients to mobilize joints, reduce any kind of soft tissue restrictions with soft tissue mobilization techniques, trigger point release, various grades of joint mobilization to improve mobility.
When you have a chronic disease, sometimes it cannot be cured, but you can definitely educate a patient on how to manage their symptoms, live with it in the best way possible.
So some of the exercises that they have recommended, the cervical rotation, which is turning your head towards the side, then returning back to looking straight ahead. They have that repeating it 2 times, holding it for 3 seconds, and completing 2 sets. They suggest that you perform this 1 time a day. They also have the cervical side bend, which is tilting your head towards the side, then returning back to look straight ahead. Be sure to keep your eyes and nose pointed straight ahead the entire time. Their suggestion is that you repeat this 10 times, holding it for 3 seconds and completing 2 sets. Perform this 2 times a day. The scapular retractions is draw your shoulder blades back and down. Repeat this 10 times and hold it for 3 seconds. You can complete 2 sets and perform this 2 times a day. They also suggest the single knee to chest stretch. While lying on your back, hold your knee and gently pull it up towards your chest. Repeat this 10 times and complete 2 sets. Perform 2 times a day. The seated cat-cow. Sit in a solid chair, halfway towards the front. The cat portion is roll the pelvis back towards the tailbone. Round the back into an exaggerated slouch. Reach arms forward, resting hands on knees if needed. The cow portion is roll the pelvis forward towards the pubic bone. Arch the back. Reach elbows back, squeezing your shoulder blades together. You should complete this 10 times and complete 3 sets. You only have to do this 1 time a day. Rows, mid with a TheraBand. Use a single strip of TheraBand approximately 3 feet long. Wrap the middle portion of the band around a doorknob. Then run the 2 ends through the doorway and close the door. Stand with feet at hip width apart and a slight bend in the knees. Begin by grabbing a hold of each TheraBand with a minimal tension and arms stretched out in front of you. Initiate each repetition first by squeezing the shoulder blades together, then pull the bands by bending the elbow backwards and downwards, and while keeping forearms parallel with the ground. Hold for 1 second, then slowly return arms to starting point and relax shoulder blades. Repeat until set is complete or until fatigue. You should repeat this 10 times, hold it 1 second, and complete 2 sets. Thank goodness you only have to do this 1 time a day. I don't think so. The next is bridging. While lying on your back with knees bent, tighten your lower abdominals, squeeze your buttocks, and then raise your buttocks off the floor bed as creating a bridge with your own body. Hold and then lower yourself and repeat. You can repeat this 2 times and complete 10 sets. Perform 1 time a day. Standing heel raises. While standing, raise up on your toes as you lift your heels off the ground. Repeat this 10 times. Complete 3 sets. and perform this 1 time a day. Gastroc Stretch. Standing facing the wall, place hands arm's length away and at shoulder height for balance. Stand in staggered stance with back leg straight, toe pointed forward, pointing toward wall and heel firmly on ground. Lean forward, maintaining back leg position and bending front knee until stretch is felt in the back lower leg. Keep trunk up tall. Repeat 3 times, hold 30 seconds, and complete 1 set. This is performed 1 time a day. Standing march. While standing, drop your knee, set it down, and then alternate to other side. Use your arms for support if needed for balance and safety. Repeat 10 times, complete 2 sets. Perform 1 time a day. Hip abduction standing. While standing, raise your leg out to the side. Keep your knees straight and maintain your toes pointed toward the entire time. Use your arms for support if needed for balance and safety. Repeat 10 times. Complete 2 sets and perform 1 time a day. Bicep curls. Slightly squeeze your shoulder blades together and lift your chest. Engage your stomach muscles. Hold this position while you curl up and down. Use a light or no weight and progress as tolerated. Repeat 10 times and complete 2 sets and perform 1 time a day. Finger opposition. Move from position 1 through 4, touching your thumb to each finger pulp. Repeat 10 times, complete 3 sets, and perform 1 time a day. Doorway stretch. While standing in a doorway, place your arms up on the door jamb and place 1 foot forward through the doorway as shown. Next, bend the front knee until a stretch is felt along the front of your chest and or shoulders. Your upper arms should be horizontal to the ground and forearms should lie up along the door frame. Note, your legs should control how much you stretch by bending or straightening your knee through the doorway. Repeat 3 times, hold 30 seconds, complete 1 set, and perform 1 time a day. Supine active hamstring stretch. Grasp behind knee and keep leg at arm's length. Extend leg up until a gentle stretch is found behind your knee. The opposite knee can be bent or straight at your therapist's discretion. Repeat 3 times, hold 30 seconds, complete 1 set, and perform 1 time per day. Thank you. This presentation, let's see if I can catch it. I'm sorry, we're moving in and out of this. So this presentation was Miss Alicia Zaveri, and this is the information that she has provided for if you have any further questions, you can call the center and learn more about the center if you want to go to the website. I will put this all in the chat again, and that concludes her presentation and my assistance in this. It does.
Thank you very much.
Thank you all. Go ahead, Joe.
Okay, well, thank you, Benita. And of course, we're pleased that all of you were able to join us today. We also will share the recording of this session so you can actually go back through it with Lou August and his team, and they will make it available to you after today. So hopefully you enjoyed this session and got some good information out of it. I know I did. I'm getting ready to do some exercises right after this session. So have a good rest of your day, and we look forward to meeting with you all again next month. Thank you.
Oh, Jesus.
Are we home? Anybody home? That it?
Hi, how are you, William?
I'm okay.
Did
I
you
got
get a
my
chance to
arthritis
see the,
going.
did you get a chance to see the presentation?
Yeah, I did. I was in the bathroom and I had it on. And I've had arthritis. I've been dealing with it 15 years. I had a new hip, a new knee. They've given me narcotics for 15 years, get addicted to, you know. So that's always another issue that I have to keep on top of, you know. I mean, you they gave me oxycodone back in 2007, been giving it to me now 15 years. So
oh wow.
Yeah, well, just have to watch it. What else am I going to do? I mean, it's addictive, so you can't take it 15 years and not have to be very aware and cautious. And so
Absolutely.
that's another part of it. But I do have arthritis. I try to keep it under. I try to stay active.
All right.
You know.
Well, I'm glad to see that you joined us. I
Yeah,
did
well,
put
I
the,
mean, I've had you on, and I've been around, and I've been listening.
good, good.
But thank you.
You're welcome. You're welcome. All right, I'm going to leave it on for one more minute. So if anybody wants to copy the email address, I'm sorry, the online address or the phone number for Miss Alicia's organization, you can copy that in the chat.
There was a couple of people who asked me to be more part of it. I said, no. I was
All right, everybody, I am going to close this down. So please have a wonderful day and stay warm out there. Thank you.
What you gonna get?